in New York. We are just so privileged to have with us tonight Dr. Robert Myers, and I'm going to tell you about him in just a minute. But Bob, we are so grateful that you are here with us tonight, so welcome. So let me introduce myself. My name is Mary McKay, and welcome to the NYU Silver School of Social Work. I have the real privilege of directing the McSilver Institute for Poverty Policy and Research, and we will be hosting this webinar tonight. I'm joined by my very experienced, smart colleague to my left, Dr. Peter Campanelli, and Dr. Campanelli will be moderating our discussion tonight. So with that, Bob, you're looking very handsome on our WebEx screen, and so let me introduce our speaker this evening, and we are so looking forward to your remarks. So Dr. Bob Myers is the Senior Deputy Commissioner and Director of the Division of Adult Services, the State Psychiatric Centers, and the Managed Care for New York State Office of Mental Health. So you have many job descriptions, I think, in that one title, Bob. You have responsibilities including policy and planning for adult mental health services in 57 counties in all of New York City, oversight of 15 adult psychiatric centers, and your recent focus has been really your tireless work on health home and managed care implementation across New York State. Prior to this huge responsibility, you managed the day-to-day operations of OMH's Division of Community Care Systems Management. So we are delighted to really hear your remarks. I know that many of you on the line right now as you're lining in can see the chat box that is also on your screen. So as you come up with questions, as you have burning issues that you hope that Bob will discuss, please make sure that you use that chat box function, and Dr. Campanelli will be moderating and asking some questions. So we'll try to be as interactive as we can. And Bob, with that, thank you again for being with us. We're delighted that you're here, and that we're looking forward to your remarks. Thanks.
Well, thank you, Mary and Peter. I'm very pleased to do this, and thank you for everybody that's listening in and interested in this topic. What I was asked to do was to really kind of present what's happening around behavioral health for Medicaid redesign, health homes, and integrated care, which is the title of the presentation. So that's what I will do, and I think the way we have this structured is I'll be presenting. Peter may ask questions throughout. He may ask questions that he thinks of. He may raise a question that somebody sends in, and then at the end we'll also address questions that people are raising. So the first thing is that I think probably all of you on the phone realize that the environment that you've been living in is changing dramatically and rapidly, and it's going to have an impact on all of us, but more importantly, an impact on the people that we serve through the organizations that we work with. So in New York State, there's Medicaid redesign. I was just listening to a webinar today presented by Jason Helgerson, the Medicaid director, where he was talking about where Medicaid redesign is going and where they are with the large waiver. But he presented some data on the accomplishments to date, and they have, quote, bent the cost curve, not only as growth has lessened, there's actually a bit lower level of expenditure at the same time that there's more people being served, and they are starting to get some quality results from some of the efforts. The Federal Affordable Care Act is another component of this. I'll be talking about that more. The thing that everybody hears about that right now is the exchanges, bringing people into health insurance that don't have it, the problems on the federal level. On the state level, I think it's doing quite well. I heard that there's something like 90,000 people that have signed up in New York now. But beyond that, there's other aspects of the Affordable Care Act, which I'll be touching on. The federal government talks about the triple aim, and all of these efforts are really focused on that. They want to improve the population health of the general population. They want to improve the individual experience of an individual patient or person in the care system, and then they also want to address costs. So that is the triple aim when you hear about it. And unfortunately, throughout all of this, there is parity, and parity legislation was passed in New York, but was also passed federally back in 2010, and they just came out with final guidance on it, which is very, very positive. So there will be parity in all of these efforts, which will give people behavioral health insurance as well as physical health insurance. So what I want to talk about a little bit in general are the opportunities that are out there for people that work within the system, things that are coming. I know it's a scary environment, but it's also an environment that presents some, I think, opportunities, first of all, to improve the care of the people that you work with, and also to improve your organization. So there's primary care medical homes. It's part of the Affordable Care Act, and it's really trying to raise the bar on care in primary care. And actually, New York is the state that has the most primary care providers that are meeting the standards of primary care medical homes. So that's a positive move. The exchanges are now going on, and again, we know the problems on the federal level. It's working well in New York, and that means a lot more people are going to have insurance, including behavioral health insurance, starting very soon. And I mentioned parity. Health homes, which I'll be talking about in detail in a couple of minutes, but health homes, I don't think people realize, is part of the Affordable Care Act. And the Affordable Care Act didn't just start with the exchanges. It started some time ago, and health homes was one of the major initiatives around that on disease management. Electronic medical records. More and more organizations are moving in that direction, either partially or fully. And actually, the Health Home Initiative is requiring that health homes move towards electronic care management records over the next couple of years. The Health Department has provided some resources for electronic medical records. And I was just in a conversation today about as they get additional help from the federal government, they're going to try to make more of that resource available to the behavioral health community. We'll be talking about carving in the behavioral health benefit into managed care. And then at the very end, I'm just going to take a couple of minutes on something else that will be affecting health, which is an integrated pilot, a Medicare pilot called FIDA, or Fully Integrated Dual Advantage. I decided at the last minute that we should touch on that briefly because things are actually happening out there on the ground now. So why must we integrate care? By integrate care here, we mean the integration of physical health care and behavioral health care. Why is this important? Well, just very quickly, the World Health Organization talks about the global burden of disease, and they present worldwide data. And this is consistent with data that comes out of this country too. Four of the leading 10 causes of disability for people over, actually this should be for people over 5. That wasn't a mistake in the presentation. Basically they're saying when you take young children out, anybody over 5, 4 of the 10 leading causes of disability are behavioral health conditions: depression, substance use, schizophrenia, OCD is in there. And among the developed nations, and this is critical, including the United States, depression is the leading cause of disability. The actual leading cause of disability in some of the third world countries is lower back pain, I think partly because of the nature of the work that so many people do, and still agrarian lifestyles. The developed world, it's depression. It's the number of days of lost productivity due to depression. These are statistics by Ron Kessler, who's a mental health epidemiologist out of Harvard, and he's put data together that shows 1 of 4 adults have a diagnosable mental disorder in any given year, and 1 in 17 have a serious mental illness. I don't think people realize that the prevalence of serious mental illness is that high. Now, somebody could say, well, this is good information, but shouldn't these people go into the behavioral health system and get treatment? Why do we need to talk about the integration of care? So that's what I want to focus on next. This is data that was put together by the Health Department a while ago. They were looking at what they call potentially preventable readmissions. In other words, somebody that was discharged from a hospital and was readmitted within 30 days when it didn't appear that was necessary. On the health side, it could have been an infection for a wound, not following up on medication. The same thing on the behavioral health side with medication, not connecting with ambulatory care. So it said about, so the first thing is we're going to talk about that in a minute. This is showing that 58% of the adult population has a medical condition at any point in time. And about 25% of the population has a behavioral health condition. That goes back to the previous slide from Ron Kessler, 1 in 4 people have a behavioral health condition. But look at the overlap. About 29% of adults with medical conditions also have a mental health disorder, and more notable, 68% of people with a mental health disorder also have a physical health condition. There's just such an overlap, and how could we, for all these years, have completely separated those two systems of care? Now, this is what I was starting to talk about a minute ago about the potential readmissions. They looked at a cohort of people that was about $814 million in expenditure, and of that cohort of people they looked at about the readmission rate, about 82% of those people, 82% of the spend had a mental health or substance use diagnosis. Only about $149 million of that was spent on people that didn't have a behavioral health condition. But then if you look at that kind of yellow part of the slide and move it over, that smaller circle is actually just looking at that $665 million, 82%. It's showing that the majority of expense for those folks, even though they had a behavioral health condition, was for a physical health admission that led to a readmission. So somebody may have had a mental illness or a substance use disorder, but they were admitted for diabetes, or they're admitted for hypertension or asthma or some other condition, and then they were readmitted. So what this is showing is that although there's large expenditures on behavioral health, for that same population, there's even larger expenditures on the health side. And that's one thing that's really kind of driving us to look at the concept of integrated care and within managed care. Now, this comes from SAMHSA. It's some information that has come out recently, and it compares the prevalence of physical health, chronic illnesses to the general population versus people that have mental illness. And in every case, the mental health population has a higher prevalence. Blood pressure, smoking. Smoking itself isn't a chronic illness, but we all know that it leads to multiple chronic illnesses. It actually contributes to most of these other chronic illnesses that are here. Heart disease, diabetes, obesity, and asthma. Now, just to bring this a little closer to home, I want to talk about smoking, and I want to show you some additional health department data. The reason I want to focus on smoking for a few minutes is that it's such a driver of chronic health conditions, and it's obviously a variable in early death. We've all heard that statistic that's been spoken about the past several years about people with serious and persistent mental illness tend to die younger, as much as 25 years younger. And we've been saying that the main reason for that isn't mental illness. About a third of that's explained by suicide, unfortunately, but about 2/3 of it explained by early death from chronic illness. And the majority of those chronic illnesses, one of the main precipitants is smoking. So there's been a huge public health push over the past 20 years, even going back to the 1960s, to reduce smoking. I remember when I was a kid growing up in the 1960s, lots and lots of people smoked, and then you started to hear how bad it was for you. And then people started to try to stop. A lot of people did. And sure enough, when you compare the percentage of the population that smoked in 1965 was 45%, it's down to 20%. But when you look at the people with serious mental illness, it's remained at 50 to 60%. So back in the 60s, they were slightly higher than the national average. That statistic has not declined as the general population statistic has declined. And another statistic that's really startling, about 40% of the cigarettes smoked in this country are smoked by people that have a history of mental illness. So one opportunity, I think, for behavioral health providers is to really have a focus on this. Some of you that are working out there in the field, when we did our PROS program, our rehabilitation license, when we made the first change to it, we actually added smoking as a dual disorder, and we actually said that you could use the higher reimbursement there to address smoking cessation in this population. And CMS didn't stop us from doing that. So we now have some evidence-based approaches to reducing this. Our Center for Practice Improvement out of Columbia University actually has some information up on the web, distance learning materials. We provide technical assistance to rehab providers out there around addressing this. Also, there's medications that that help people to stop smoking, nicotine replacement therapy. Now, the health department has restrictions on it. It could only be prescribed so much in a given year. If you start a trial and you don't finish, you might not be able to have another trial. What we're doing is as we're putting our managed care design together, we're working with the health department to lift those restrictions for behavioral health, and we're starting to talk to the managed care plans around their drug formularies to say it would really be not only in your members, patient's best interest, but in your best interest from a financial perspective to be more aggressive with this therapy in your drug formularies, because it's really going to reduce the burden of chronic illness in the population that you serve. But there's really a counseling component to this, and I think it's an area that behavioral health providers should really get into much more than they have. There's a counseling component in rehab programs that are day-type services. I've seen clubhouses that have actually created a culture in their clubhouse about smoking cessation, and people support each other, and people are recognized for it. And I'm trying to emphasize that this is really an area you should think about, and if it's an area that you want to get more information in, you could get that through the Center for Practice Improvement. So this is a busy chart, but it's really important. This was when the health department started to look at health homes, and they started to identify people that had high risk scores. In other words, high scores for being expensive. They did some analysis of their Medicaid claims data, and they were able to look at individuals and then determine based upon the claims the nature of the illnesses that they had. And they ranked it by total risk scores, and the first three, you look at it, serious mental illness, and substance use. That's the row. When you look at the columns, if you look at the serious mental illness columns, of all the people in that category, all of them have serious, 34% have hypertension, 28% have hyperlipidemia, 23% have diabetes, 34% have asthma. Going over to the right, 31% have cardiovascular disease. And those numbers bear out with people that have a more modest mental illness and also people that have substance use. And then if you look at people with serious mental illness, 77% also have a substance use disorder, these high-need individuals. And again, for those of you that are out there practicing either as clinicians or administrators, I don't think this is news to you, but when you look at the statistics, it's stark. And it really shows why that chart I showed earlier is saying that the health expenditures on this population are even higher than the behavioral health expenses. So I think this is really a compelling case for why we need to integrate care. So now I'm going to switch to some initiatives that could help us do that. I'm going to talk about health homes. As I mentioned, health homes is part of the Affordable Care Act, and the federal government actually provided incentives to the states to move towards health homes. Now what is the concept of a health home? So the Affordable Care Act talks about primary care medical homes. Those are really more your primary care practices that focus on your physical health for not necessarily a well population, but a lot of people go there for physicals. You go to your primary care doc. Now, as we know, there's very few independent primary care docs anymore. They're mostly parts of larger practices. A lot of them are being bought up by hospitals, but those are primary care medical homes. And the Affordable Care Act is incentivizing medical record use there and quality approaches. But I think everybody realizes that one of the two biggest drivers for health care in our country are the long-term care system, nursing home, and chronic illnesses. We've done a good job in this country on managing costs on the day-to-day colds and infections. But on chronic illnesses, our lifestyle, our eating habits, our culture is just a driver for chronic illnesses. So health homes are focused on chronic disease management, and for the Medicaid population, if somebody has 2 chronic illnesses, they'd be eligible for a health home. But interestingly, the federal government realized that serious mental illness was such a driver of health that even if you just had a serious mental illness without another chronic illness, you would be eligible for a health home. So the first group of folks we moved into the health home were actually people with serious mental illness and substance use disorders, as well as the HIV population. We looked at the case management system that we had out there through CMS, our intensive case managers, our supportive case managers, and we moved those 23,000 case management slots along with the individuals in them into health homes. And that became the foundation of building the health homes. And now we have health homes in, I think, all but 4 counties in the state. In New York City, we have quite a few in each borough. The concept is increased accountability, especially for reducing avoidable readmissions and reducing emergency room presentations. Integrated care, so the plan of care that's put together there isn't just the behavioral health plan of care, it's an integrated plan of care that looks at the person's health, their behavioral health, and their social support needs, so looking at income and housing stability. So these are the plan of cares that are put together, and I know that there's been various efforts, partly funded through the health department, to provide training to care managers on the ground about how to do integrated plans of care. And over time, they're going to be developing metrics for better treatment and recovery outcomes. I had mentioned that on the mental health side, the case management program has moved into these health homes. Now I want to talk a little bit about why providers and why recipients should really join health homes. So as I've been out there talking about this, especially in the beginning when it was first starting and some providers were going, well, why should I join a health home? Now, a health home isn't just the care management. The heart of a health home is the care management. So, and that's where the federal incentive came in. The federal government's providing a 90% federal match to care management in health homes for 2 years to incentivize states to move in that direction. Typically, New York gets a 50% federal contribution for Medicaid services. For health home care management, we're getting a 90% federal contribution for the first 2 years. But the care management is just the component of care management. The health home is a network of providers, of hospitals, of primary care providers, of behavioral health providers. So the Office of Mental Health worked very closely with the health department and OASIS to review health home applications. And one thing we looked at was the adequacy of their network. Did they have a range of services that included behavioral health, not just health, and did they have an adequate number of providers for access? So a health home is actually a network of providers focused around care management. So what we've been saying is providers should really join health home networks if you're not already part of them to really get connected to the future. The health department is really looking at health homes as the network integrator on the ground going forward. They're working with managed care plans to work with health homes. And as we move behavioral health into managed care, we're going to be requiring the managed care plans that are working with the people with serious mental illness to provide care management through health homes. So you'll be part of an integrated care team. You'll have access to referrals. Now, right now, because these health homes have just come together, people that are getting their care, some of it in the health home, some of it somewhere else. But over time, I suspect that as these health homes become really integrated networks and not just kind of an amalgamation of providers that signed agreements, you're going to start to see referrals stay more within the network. I know right now there's 2 large hospital systems in Albany, St. Peter's and Albany Med. My primary care doc is with St. Peter's system. So when I go to him, if he refers me to a specialist, he tends to refer me to a specialist that's part of the network that he's part of. And I think that over time you'll see that happening more. So you'll have access to referrals. Whether you're a care manager that puts the plan of care together or you're a clinic provider or a rehab provider, that's where you'll start to get more referrals and business. And I think it's very important if you become part of a health home network to make sure that the care managers are aware of the services that you provide so they think of you as a referral source as they put a plan of care together. I mentioned earlier that there's a requirement that over 2 years that health homes should be using electronic records, and I know there's been a lot of work on the ground now about various electronic care management tools. Health homes are looking at connecting to RIOs, so you'll be part of that whole thing. There's a focus on accountability, so over time the health department will be collecting and publishing metrics around how health homes are doing on reducing inpatient admissions and producing better health outcomes. And if you're part of a health home that's providing good outcomes, managed care companies as well as members of managed care plans will have access to that information. So it's important to get hooked up with a health home that's doing good work. You'll be positioned for managed care. And we've been saying to behavioral health providers that you should really be approaching these health homes not as, can I join, but what you could bring to the table. You obviously provide treatment. A lot of you provide care management already. You're providing rehab and recovery services focused specifically on behavioral health. And this is very important because a lot of the people that the health department's referring to health homes aren't well connected to care. They may be expensive on inpatient and ER, have hardly any ambulatory billings because they tend to use the ER for their medical problems, and they're very difficult to engage or to motivate. And the behavioral health provider community has skills on motivation and engagement. You could provide a valuable connecting component there. And you also bring housing and employment services and peer services to the table. In terms of recipients, we've been saying you'll have a better experience of integrated care. You'll be working with a care manager that'll put an integrated plan of care together for you that helps you with your health issues as well as your behavioral health issues. And they'll help you navigate the system to get better access to services, better care management. And my hope over time is that the better health homes will actually start to focus on rehabilitation and recovery and skill development. I know, we're not there yet. I also wanted to say that I know that, the startup of health homes throughout the state has varied from place to place, and some of you that are on the providers in the system have probably had more positive experiences than others. But over time, I think those issues will be addressed. And the fact that health homes are going to become part of the system of care as we move into managed care, I think that their capacities will be enhanced. So the next thing I wanted to talk about was what's going on with Medicaid redesign. So I think everybody knows that when the governor came in and he started to work with the health department and they brought Jason Helgerson as the Medicaid director, the notion was that every a Medicaid recipient over time would be moved into managed care, and that for anybody that needs it, they would get care management. There's this kind of mantra, care management for all. And that included the behavioral health money, the mental health fee-for-service money, and the OASIS dollars. Now, many of you know that most people that served in the public mental health system in the state now are in managed care for health. If somebody doesn't have a serious mental illness, if they're not on SSI or some other benefit, their inpatient in their clinic is carved in, but their specialty services are carved out. For the SSI population, all those specialty services are out, as well as inpatient and clinic. So we do have this split system now where the health benefit's managed. In large extent, the behavioral health benefit isn't managed. And if you go back and think about the data that I talked about a little while ago on the health side, a lot of the folks that are being served on a fee-for-service basis in the behavioral health system are in managed care on the health side. And I think we all know that especially people with serious mental illness, it's very difficult for individuals to effectively manage their health care if their mental health care isn't under control. If somebody has a thought disorder with an overlay of depression or anxiety, they have trouble following through on the recommendations on their health care for diabetes management. A lot of people have sedentary lifestyles. Their eating habits aren't the greatest. And it's really a driver on the health side, and it's very hard for individuals to kind of get their arms around both lifestyle and following treatment. And I think that's an area with integrated care where you'd be able to help people with the symptoms and the functional issues of their mental health or substance use condition that has an impact on their ability not to be able to manage their physical health condition. And we also know that some of the medications that are used for the behavioral health conditions have a metabolic effect. And if mental health professionals are in the middle of the mix there and we start working with prescribers, I think we could start having an effect of trying medications first that have less of a metabolic effect, as long as that's indicated as a viable option for an individual. And if somebody does respond well to an agent that has significant metabolic issues, their primary care doctor should know. They should be fully informed of this, and from the beginning, when they start taking a medication that could have a metabolic effect, they should be working on diet and exercise and monitoring their health conditions. And that's where real integrated care comes in. I think I want to emphasize that. As I'm out there talking to the managed care plans now, I don't just talk about health and behavioral health, I talk about pharmacy too. And a lot of the behavioral health pharmacy is being delivered through our clinics and our PROS programs. So you folks that are on the call that are managers of systems of care, I think you need to start thinking about on the pharmacy side how the pharmacy that you do in behavioral health interfaces with the health pharmacy, and also communication between what you're doing on the prescribing side with the healthcare, the physical healthcare provider of your of the patients that you serve. And so, many of you have access to the Psyches tool that the Office of Mental Health has developed and refined over the years now, and I think that's a very useful tool to help address these issues. It was originally designed to address polypharmacy, and it's expanded from that. Another one of my recommendations would be if you're working in an agency out there and you don't yet have access to that, you should look into getting it. So this is actually the timeline for moving the behavioral health benefit into managed care. I'm not going to go through each of these boxes, but I do want to cue in on a couple of things. If you look at the first column and you go to the box that says October, we're a little behind. What we're doing is we're moving the behavioral health benefit into managed care through the mainstream plans. There was a discussion about should we do a behavioral health carve-out, should we do an integrated benefit carve-out. The challenge there was all these folks were already in managed care for health, and we didn't want to replicate a split between health and behavioral health by carving the dollars out, and if we did an integrated premium and moved them into a special needs plan, you'd be moving them out of their mainstream plan, and they might not have access to their health care providers any longer, depending on the network of the special plan. So the decision was to move the dollars through the mainstream plan, which I'll be talking about more in a little bit. So, but in order to do that, we have to make sure that these mainstream managed care plans have the knowledge and experience, the proper staffing, and the proper focus to manage this deep-end behavioral health benefit. So we're going to go through a qualification process. We're going to be developing a request for qualification application, and the mainstream plans, before they get access to the behavioral health dollars for the people that are in their plan, will have to demonstrate that they qualify, and I'll talk about that in a little bit. We moved the start date in New York City up 9 months to give us some additional time. Because of that, we have the opportunity to refine that request for qualification. So actually tomorrow, the Health Department, the Office of Mental Health, and OASIS are going to be issuing a draft request for qualifications along with an RFI, a request for information. And it's going to be on our website. We're going to be sending it out broadly to stakeholders. We're going to be sending it to trade associations, to the Medicaid Redesign folks, to county mental hygiene directors, and we're going to be, and to managed care plans. And we're going to ask that people review the RFQ. It's a draft, and respond to the questions that we raise around input, because we want a broad stakeholder input about how to improve the RFQ document to make sure it's done in a way where plans will be able to demonstrate they can qualify. So keep an eye out for that. We really would encourage your input, but also when you read it, you'll start to get a more granular sense of what this is going to look like. There's a lot of information in there about what we're going to require of the plans around staffing within the plans, qualification of the plans, medical staff within the plans, utilization management, network development, partnering with networks, medical necessity criteria. So again, that's coming out tomorrow. And then we'll refine that. We'll issue the RFQ in February of 2014. We'll start to let the plans know how we respond to that. We'll start making designations of plans that are later in the year that they're qualified to become to accept these dollars, and then we'll start working with the plans to prepare for that. January, we're in the third row now, January of 2015, we're planning to go live with this in New York City, and July of 2015 throughout the rest of the state for adults. And for children, we're looking at January of 2016. So that gives you a flavor for the timeline, but most importantly right now, this RFQ that's going to be coming out, I expect it'll be coming out tomorrow. So the Medicaid redesign team initially worked on a couple of hundred initiatives to better manage the system. And when we did that, Office of Mental Health worked closely with the health departments in the area that affected behavioral health. There was a realization that bringing the behavioral health benefit in, especially for, quote, the deep end population, people with serious mental illness, was very complex, and we needed more time to really think that through, and we needed input from the larger behavioral health community out there. So we set up a behavioral health work group within the Medicaid redesign team, and we worked for about 6 months. We produced a report that was submitted to the Medicaid redesign team, which they really liked. They were very positive about it. They approved it, and the governor's office accepted that report. That report is available through the OMH website, the health department managed care website. But these are the principles. So we're actually using that report as a blueprint to design bringing the behavioral health benefit in. And these are actually some of those principles. Person-centered care management. In other words, when you do care management, it has to be focused on the individual, getting information from the individual, focusing on the person's goals. It's not just a medical model symptom management approach. It's an engagement model. And this is another opportunity, I think, for the behavioral health community. A lot of behavioral health providers have a lot of experience in person-centered planning and engagement and involving the consumer in the plan of care. In fact, in many of our license programs, we require the consumer to sign the plan of care. And our intent there isn't just pro forma. Our intent is that they were part of it, and they're indicating that they really agree with about that plan from the perspective of what they want help with and what they want to accomplish in their life. Integration of physical health and behavioral health was one of the principles. I've talked about that. A recovery orientation, I'm going to talk about that more in a little while. Patient and consumer choice. Again, many of the behavioral health providers out there have for years the concept of choice for individuals. So you'll be able to bring that to the table as a network partner with a plan. Ensuring adequate and comprehensive networks. The plans, although we may have a minimum standard of at least 2 of a certain type of provider, that might be adequate in the rural area in, say, the borough of Brooklyn or the Bronx. You'll need many more than 2 of a service. They're going to have to demonstrate that they have a network that's adequate to meet the needs of the number of people that they have enrolled in their plans. We're also going to require initially that if the plan looks at their membership, and they'll be given information about where their members get behavioral health services from claims and encounter data, and then any plan that has somebody that has at least 5 of their members with a particular provider at the point in time that this starts, they'll have to contract with that provider initially. And then after 2 years, that requirement will go away. By that time, the plans and the provider systems will have learned how to work together, will get to know each other, and where there's good working relationships, that will move forward. So there's going to be plenty of opportunity to join networks. The other thing that we're looking at is requiring initially that the plans pay government rates for most of our ambulatory services. There's actually statute for that now for a clinic, but we're looking at that for the other services too. But there's going to be one caveat there, because already we're starting to see some network development going on with providers that have come together around health homes. They've created practice organizations, and they're starting to talk to some of the plans. And they've started to talk to some ideas about maybe there's other ways to get reimbursed. Maybe there's pay-for-performance models where if we provide good outcomes, we could share in some savings. So we're going to be saying for the first 2 years that the plans will have to pay government rates for what were these fee-for-services, but in a particular market, if a particular plan and a group of providers that have formed a network come and say, maybe in the second year, we would like to try a different payment model, and it looks like it's reasonable to try, and it's clear to excuse me, it's clear to OMH and OASIS and the health department that this really is a collaborative model. It's not the plan trying to reduce payment to providers. It's the network coming together with the plan to say we want to approach reimbursement differently because we think with more flexibility we could produce better outcomes and we could also save dollars. So, you know, that'll be something we'll be talking more about going forward. But just for kind of an assurance perspective, we will be looking at government rates initially. That doesn't mean that the plans can't do utilization management. It doesn't mean that they can't steer referrals towards providers that are producing better results. Payment tied to outcomes, over time, initially we have to get this started, but in year 2 and year 3, we're talking about holding back a small percentage of the premium as incentive payments to the plans to start producing outcomes. They'll obviously be working with their networks to produce those outcomes. We want to track physical health and behavioral health separately. We want to make sure that behavioral health dollars goes to the behavioral health population on the ground. It doesn't go to profit. It doesn't get redirected. So we are going to be protecting those dollars. We want to reinvest behavioral health savings, which we'll be talking about more, and we want to obviously address the children separately. We have a whole separate planning process on kids to make sure we get that right. So, you know, we're going to be doing several things here. We're going to be moving about $1 billion of mental health fee-for-service money into the plans. And besides having a special focus on people with serious mental illness, which is the special needs product line I'll talk about next, we're going to use it as the opportunity to raise the bar on behavioral health across the plan. So at this point, we're talking about starting to move towards depression screening, anxiety screening, and substance use screening in primary care settings. Now again, that could be another opportunity for behavioral health providers to get referrals from primary care when people screen positive. We're looking at collaborative care models where a primary care practice will collaborate with a behavioral health organization to have some on-site presence and to have psychiatric consultation to their primary care docs for complex cases. So that's one thing we want to do. We want to raise the bar in primary care around integration for the general population. But the next thing we want to do is we want to really look at the deep end population. So as we move the state plan benefit services in, whether or not a managed care plan wants to have a separate product line, which I'll talk about a little bit, we're going to be really having enhanced metrics on deep end behavioral health in the mainstream plans, and that's what plans are going to have to qualify for. But beyond that, we want to develop a separate product line in the plans that are interested in working with us, which we're calling health and recovery plans, or HARPs. So the idea with that would be that it wouldn't be a separate managed care plan. It wouldn't be a separate license. But within their existing license, they would create, quote, a product line within their existing license. It would almost be like embedding an integrated premium special needs plan within their existing managed care plan. We've identified about 140,000 people that we think would qualify for this based upon an algorithm we put together of service utilization, diagnosis, functional information. And what we would do is in that product line, we would have an integrated premium. So, for example, in a plan that had 50,000 members, let's say 5,000 of them will qualify for this HARP, we'd be passively enrolling that person in the HARP product line. They could choose to say, I don't want that, I want to go back to the mainstream plan, but they wouldn't have access to all the benefits that I'm going to talk about. But the average spend for this population is significantly higher than the total population. So I'll talk about that in a few minutes. Okay, so these are some of the criteria that we're going to have in the RFQ. These are clinical management criteria. When you see the documents later in the week or when you see it over the next couple of weeks, you'll start to see some of this. And I wanted to point out some things here that I think would be of interest to the behavioral health community. We're going to be asking that they manage people with complex conditions with high costs and co-occurring behavioral health conditions. A lot of these people have mental health and substance use conditions. A lot of providers out there have expertise in that. Our Center for Practice Improvement actually has web-based distance learning for people to develop a clinical expertise in dual disorder treatment now. That's something you should really be looking at for your members. Interestingly, that's called the FIT program. We actually got a call last week from one of the managed care companies. They hired somebody that had worked in the behavioral health community, and the agency he worked in, he was a senior clinical person. He sent several of his staff through the distance learning modules on integrated dual disorder and was impressed by the quality of it and the ability it gave the staff to do that. And this person was actually asking, can you tell us which providers out there have sent some of their clinicians through this training, because we want to use that as an indicator of where we might want to make referrals for people with dual disorder issues. So I think going forward, workforce training and evidence of workforce training in specialty areas is going to be very high on the agenda. We're going to be talking about the promotion of evidence-based practices. We're going to want the plans to have evidence-based practices in their networks, again, through our ACT program, through some of the services we've embedded in PROS, wellness self-management, family psychoeducation, integrated dual disorder care, some of the tobacco work that some of you are doing. We have evidence-based practices out there now that the plans are going to be looking to partner with. I talked a little bit about drugs. We're going to be asking the plans to focus more on this. What I'm finding is that most of the plans contract with specialty pharmacy management companies like CVS, but they also have in-house pharmacists. And I've had some conversations with some of their pharmacists about, how are you going to work with these specialty pharmacy benefit managers to focus more on this population. So one reason we want a health and recovery plan is not just to focus on the integrated care of health and behavioral health, but also to focus on the complex pharmacy management here. And again, the physicians and nurse practitioners in your system will be part of that conversation. So we're going to be raising the bar for the deep end behavioral health population in the mainstream plans, but then we're going to add additional services if a plan becomes a health and recovery plan, this product line. We're going to have additional metrics. We're going to have enhanced administration for the plan because we're going to be asking them to do more. And very importantly, we're going to be moving home and community-based services into these plans, so they'll have benefit package, and I'll talk about that more in a couple of minutes to give you a better sense of what that is. So this is just a comparison of a mainstream plan that brings the behavioral health benefit in and decides they don't want to be a HARP versus if they do. So obviously Medicaid eligible is a given. We're talking about Medicaid managed care. In the mainstream plan, the benefits will include all the Medicaid state plan services, which we'll list out in a minute. The money has to go through an organized managed care plan. They still have to coordinate behavioral health and physical health. There'll be enhanced behavioral health metrics. And we're still talking to health department about this. We want to have a medical loss ratio. What that means is that for the behavioral health premium that goes into the plan, the vast majority of it has to be spent on care. It's an interesting term, medical loss. Insurance companies think of expenditures they have to make on the care of their members as a medical loss. It's an interesting term. But what we're saying is that the majority of money they get from fee-for-service is going to have to go out to encounter payments to providers to provide care to the population. So we're going to be tracking that. Now, in the health and recovery plan, we're going to be doing all of that, but on top of that, as I say, it's an integrated product line. The reason we want that is we want to have an intense focus on this population. In some states that just carved this population into mainstream plans with no attention, they didn't get very good results, and a lot of the money ended up going to other uses. We want to have this led by psychiatry with staff that really understand working with this population, but we also want the plans to build on the strengths they have. So, for example, we're going to want them to have physical health doctors working with the health and recovery plan, but we also want the health and recovery product line to have access to the strength that the plan has built up in general around diabetes management and hypertension management and health education for all their members. Anybody in a HARP will have full access to the health network in the mainstream plan that they're part of. And we also want to have specialty metrics and have the clinical administration of the HARP to focus on those metrics for the HARP population in their in the number of the HARP population that they have. But we also want to build on their quality management strengths in general for health. So it's going to be a synergistic relationship between an intense, discrete focus on this high need population built on the platform of the strengths that the plan already has for health management. I said they're going to get these specialty services. There's going to be enhanced care coordination. Anybody in the HARP product line will get their care management through a health home. So going back to what I said earlier about health homes, we're going to be building on the foundation of health homes. Anybody in a HARP will get their care management through a health home. So it's really important that if you're a care manager or if you have care management in your organization, you really start to focus on providing that to this HARP population. And then many of you provide care management as well as an array of treatment services and rehab services, and that would all be part of the integrated plan of care through the health home. So the plans are going to really be working closely with the health homes around integrated approaches to care. As I learn more and more about these plans and the health homes, I'm hoping we see a synergistic relationship between the boots on the ground case management or care management that you see coming out of health homes and the strength of the information systems as they start to be built on the ground in health homes. And the information that the plans have about their population, they're the payer. They'll pay encounter information. They'll get notified when somebody's hospitalized. They'll have a lot of information that you may not have within your health home. They'll be looking, they have to manage financial risk too. So they'll be stratifying their population based upon cost and expense. And so within their HARP product line, they'll say, these are my really expensive folks. What has to happen to get that under control? And I'm hoping that information will be shared with the health home to make decisions about how you stratify care management for this population. They also, some of them that have good software and approaches have some predictive modeling where they could identify people that look like they're going to become expensive. And I'm hoping that the care management focus that's really kind of more office-based and data-based at the plan level synergistically works with not only the information systems at the health home level, but also the boots on the ground care managers. I've heard from a couple of plans already that their office-based nursing care managers have started to talk with the health home case managers about high-need cases, which is an encouraging sign.
Bob,
so these are the, yes?
Bob, I've got a couple of questions that I just want to run by you very quickly. I've got one person on the line who's asking about the distance learning modules and where they're available. Could you talk a little bit about that?
Yeah, the Austin Health funds a Center for Practice Improvement through Columbia University. Right now, the head of that is Dr. Lisa Dixon. And we provide funding there. One thing, our ACT Institute is there. But what they started to do is develop distance learning modules for various areas. And one, as I said, is integrated dual disorder. So if you look at the OMH website, you could locate it. You could also look, my guess is if you Google the Center for Practice Improvement at Columbia University, you would come to their website. But Peter, the other thing I don't know if you have ways to communicate to people that have signed up for this after the fact. I could actually get you specific contact information and it could be posted. But beyond that, I believe if you did something like the Center for Practice Improvement at Columbia or Psychiatric Institute, you would come to it. Once you get to their website, it's actually a pretty good website. You could click on lots of things. You could click on the different products that they have available. And what some providers have done is they've signed up certain of their clinicians. We have a software where we could tell who signed up and who's taken modules, who's taken one module, who's taken 5 or 6. And if somebody completes all the modules, we actually issue a certificate that they've completed the course.
Yeah, let me just say that you're absolutely right. If you just Google the Center for Practice Improvement at Columbia, it'll come right up for you. You can get people's phone numbers and email addresses directly from the website. As Bob pointed out, it's an integrated program that they operate there. And if you're a licensed mental health provider in New York State, the learning that they provide is free of charge.
Should I keep going now?
Yeah, please.
Did you have another? Okay.
Oh, I
so
have one more question.
Okay.
Well, this question's a little more complicated. You talked a little bit about as the HARPs roll out, there were going to be holdbacks to payments predicated upon measured outcomes. And one of our audience would like to know what those measured outcomes would be and any idea about how those payments will be held back and how you can ensure that those payments would get to the providers downstream.
Well, this is still a work in progress, but in managed care in general, what they tend to do over time is they have incentive payments for outcomes. So in the mainstream plans right now, they have a pool of dollars that providers earn, that plans earn if they produce certain outcomes, whatever focus is at the time. It might be improvement in diabetes management, or it might be improvement in well baby visits, or whatever the health department through the information they have thinks is an area that should be focused on. What we're planning to, and the fully integrated dual advantage plans that are going to start, if you've seen any of their presentations, they're talking about a small withhold that grows modestly again for incentive payments. So it's a pretty typical approach to managed care. Our thinking at this point, and again, this is still just initial thinking, is the first year we're not going to do that because you need startup, you need all the dollars out there to get going, the plans need to pay claims on time, they need to get their networks in places, you all need how to work together. But as we watch this unfold, the plan would be, say, in year 2 or year 3, as we see it unfold, we would hold back a small amount, say 1% of the premium, to create a performance incentive pool. And then we would have identified what areas of performance we want to look at. It could be reduction in readmission rates. And in the beginning, it'll probably be things focused more on system improvements that generate savings. But when I say savings, I don't mean savings that come back to the state. So let me talk. I wanted to make sure I hit on this. If you look at the total spend on the HARP population, the encounter spend, because some of these, remember, these people are already in managed care now for health, and the fee-for-service spend and the pharmacy spend. The average spend on those 140,000 HARP populations is somewhere between $2,200 and $2,500 a month. That's the average. Some people it might be $400 a month. Some people it might be $9,000 a month. But it's a lot of money. And if you unbundle that money, about $500 of it on the average is pharmacy. And then the remaining $2,000, a little more than half is on health and a little less than half is on behavioral health. So that's kind of the pie. Actually, I was meeting with one of the plans in the Bronx on Monday, and I pulled their data, and their pharmacy spend for their potential HARP population was $473 a month, very close to the $500 amount. So but then when you look at the total behavioral health spend that comes in, half of the $1 billion we're talking about is inpatient and ER. So, and the readmission rate on the fee-for-service side for people that are discharged from Article 28 psych units is 20% within 30 days. That's a statewide number. In New York City, it's actually 22%. Now, statewide, about 75% of those readmissions go back to the same hospital. In New York City, 75% of them don't even go back to the same hospital. They go to a different hospital. So I think we have a real mess out there, a real chaos on the inpatient side. And one thing we want the networks and the plans to work with is to appropriately reduce readmissions. That will free up dollars. We want those dollars to be reinvested on the ambulatory side. And we need to make sure we improve access to clinic. When somebody's discharged from a hospital, they need an appointment within 5 days. If somebody's at risk, they shouldn't have to wait for 3 weeks for an appointment. We want to address that. And then the second thing we want to do is we want to grow rehabilitation and recovery services. So over time, my guess is that some of these modest incentive payments that we'll be putting in place will incentivize those outcomes that I just talked about. Now, the next question you had is, so if there's incentive payments to the plan, how does that then get stepped down to their health homes or to their network members? And that's going to become part of the partnership conversation that's going to happen with the plans. Obviously, the plans don't get the incentive payments unless they get the result. To get the result, their network providers have to produce that result. So there's an obvious partnership and synergy around sharing incentive payments that will, I believe, unfold over time.
Bob, two other questions came in while you were answering those two. Charles Lewis wants to know whether or not the Federal Affordable Care Act or Fed regulations are going to be operative in the new HARP arrangement that's going to be out there, or whether it's going to be controlled almost entirely by state regulations.
Well, I mean, that's a pretty broad question, and, ultimately, you have to talk to the lawyers about it. But my general question is that it depends on the aspect of the Federal Affordable Care Act. If there's a national requirement on parity, for example, you're going to have to follow that. Now, actually, the NYS email blast that come out either yesterday or today, there was actually a good one on parity. One of the people at NYS had talked to Bazelon Center about their interpretation of the parity rules that just came out. And what that said is that national parity is now the standard. If a state has a higher parity rule, then the higher parity rule is in place. And I believe in some circumstances the parity law in New York is even a little bit of a higher bar. But so the parity standard would apply. Other aspects of the Affordable Care Act will play out. Beyond that, we have to negotiate, the state has to negotiate with the Center for Medicaid and Medicare Services, CMS. We actually have a waiver amendment in front of them right now, and they've sent us several questions. And we're not going to be able to do this until we satisfy their questions. So if there's aspects related to the Affordable Care Act, they're going to be looking at that. But they look at more than that. They look at network adequacy. They look at qualification issues. So we're going to be going through a rigorous process with the federal government to design this in a way that is approvable for them. We can't do this until they approve our waiver amendment.
Bob, you said earlier that for the first year at least, once this shift into managed care occurs, that the government rates would apply, and then after that the rates may fluctuate. Is there any idea on what those rates might look like or what their levels might be?
No, our hope is that after the first couple of years, there would have been a good working relationship developed between the plans and the provider networks, and it'd be kind of mutual agreement on different approaches. So we haven't gotten to that yet. We're still trying to kind of get this out the door. And just one of our principles is that, quote, the safety net, the not-for-profit provider community out there that's been providing behavioral health services throughout the state all this year, that can't be disrupted. That safety net can't be damaged as we're moving this into managed care, and we're hoping that once that happens, we'll actually produce better results. But one of the reasons that we're looking at government rates initially is that we wanted the stability of, quote, the safety net to remain as we move this into managed care. I've explained to the plans that if they're working with a hospital, although there's certainly lots of financially distressed hospitals, hospitals get payment sources from lots of different, they get Medicare, they get Medicaid, they get private insurance, they get all kinds of things. There's many not-for-profit providers out there, especially the smaller ones, that a high percentage of their revenue is Medicaid, and that although the dually funded Medicare, Medicaid, Medicare people will be staying in fee-for-service for a while, the straight Medicaids will be moving in. So you could have a provider where a significant percentage of their revenue all of a sudden is in managed care. And if payments can't be disrupted, if a provider's payment flow was disrupted for 3 or 4 months, depending on that provider, they may have a serious problem. So the plans, we're making them sensitive to the fact that that has to work out. And one way to do that is government rates. We already have a payment system in place that they'll build on initially until there's the opportunity for the plan and their network members to come together around other approaches. So that's where our thinking is now.
So we have a couple more questions, but just being the timekeeper as well as the moderator, perhaps I could suggest that we try to get through the next several slides because there's only a couple of them left. And then
I think
go through questions.
I agree, because I think there's some important information on these next slides, and you told me in the beginning, Peter, that at 7:30 our power's cut off. We're just gone. We have no flexibility. So, so we have about a little more than 20 minutes. So these are services that you're familiar with. These are state plan services now. All these services will be moving into managed care. Now, again, I mentioned before that except for the people that are going to be in the long-term care system for the FIDAs, the dually insured Medicare and Medicaid are going to stay in fee-for-service for a while. So you'll be running a clinic, and more of your population will become managed care than it is now. But you'll still have fee-for-service people, and there's a significant number of people that are out there that have Medicaid and Medicare. So you'll still be dealing with fee-for-service. The balance will change. You'll have more managed care and less fee-for-service, but still a substantial fee-for-service business on people that are Medicaid and Medicare. But these services will be moving in. But the thing I really wanted to spend some time on, these 1915I services. Now, that 1915I is a technical term. What they really are is there's home and community-based services. Now, CMS for years has had this concept of home and community-based services. What that meant in the past was that people were eligible for institutional care, for nursing homes particularly, or for hospitals. And if there were home and community-based alternatives developed, they wouldn't have to go into an institution. But you'd have to demonstrate that they met the institutional standard. You would be able to, states would be able to develop these Medicaid home and community-based services and say we can keep people out of institutions. A while ago, CMS developed these 1915I services, which the person doesn't have to demonstrate that they are eligible to go into an institution. It was a state plan service that New York never went after because of all the federal requirements. But the consultant we're working with on designing this, Mercer, it's a national consultant, has advised that we can embed a 1915-like waiver, 1915I-like waiver in the 1115 plan. The 1115 waiver is the CMS waiver that the state uses to operate its mainstream Medicaid managed care plan now. We're going to amend the 1115 waiver to bring the behavioral health dollars in, and we're going to embed these 1915 in that. And that's one of the conversations we're starting with CMS. So these are services that we don't have in the state now, or at least we don't have as a Medicaid service. So besides rehabilitation that are more place-based, like say through a PROS or a clubhouse, we're looking at two levels of mobile rehabilitation, a more professional level and a more paraprofessional level of mobile rehabilitation. We're looking at Medicaid not to provide housing, the rent subsidy, but to provide supports related to housing. So we want to have a mobile housing support service. We want to have mobile crisis intervention that's paid for by Medicaid, and we also want to have more of like a peer-operated crisis respite service for those of you that know, say, like a Rose House type service. But we also want to be able to have trained paraprofessionals to be able to go into somebody's house if that was clinically appropriate and stay and work with that person so they wouldn't have to go to the hospital. But we also want to have a more professionally staffed intensive crisis residence program. It would actually be a residence where you could provide some emergency treatment there. That would be a diversion from emergency rooms or inpatient, or it could even be a step down from inpatient. And I know that in a couple of areas of the state, some housing providers are already stepping up and saying they're thinking about repurposing some of their housing to do crisis residential services. I know that New York City has this parachute federal grant that they're looking at crisis residential services, and we're looking to be able to use Medicaid to pay for that kind of thing. And we're hoping that this will become a service that will grow. It's not a cheap service because it's 24-hour service, but compared to inpatient, if it's used properly, it could save dollars. One thing we never did in PROS is also be able to fund supported education. We want to be able to fund supported education. We want to have Medicaid go into family support services, family psychoeducation. based upon the plan of care, if it's a medically necessary plan of care, and somebody needs transportation temporarily, and it can't be found another way, we want Medicaid to be able to pay for non-medical transportation related to accessing the services on their plan of care. It's not just take me to the grocery store. It's I need to get to this treatment service, and there's no bus, or eventually I'll be able to take mass transit, but I need some train to get there, or I have a job interview, and it's in my plan of care. Those kind of things, we just have to manage it. We want to have, we do provide Medicaid support through our PROS program now, and we also do employment through our clubhouses and some other venues. But what we've learned is that in this waiver, Medicaid will pay for additional things that they don't pay for in a non-waiver employment service, like job development. So we want to use this 1915I service to expand our ability to provide employment services. We think it could be an enhancement to PROS for additional things to do. We're hoping that, say, clubhouses will look at this as a potential Medicaid source to do some things. And we are going to be bringing peers into the workforce that Medicaid will pay for as part of a treatment team. Peers will need to be certified in order to be eligible for Medicaid reimbursement, and John Allen at the Office of Mental Health, our lead person on peer issues, is right now developing a peer credentialing process that'll be available early next year, and peers will be able to go through that training and become eligible for to be certified peers. The concept of self-directed care, you see it more on the physical health side now than you do on behavioral health. Somebody that had an accident is wheelchair bound and needs an attendant to come to their house in the morning to help them get ready for work and helps them get ready when they go home. In self-directed care, that individual could actually hire and fire that person. They're actually employed by them, and they may have somebody that works with them to manage budgets. This idea has now come to behavioral health, but how do you design that for a behavioral health service? So New York's very interested in getting into this, but we realize that it has to be done thoughtfully. Our Medicaid consultants are telling us that CMS sometimes allows a state to use Medicaid money to design and pilot an innovative service with the understanding that once that's done, it'll become part of the benefit package. So we're asking CMS to let us develop self-directed care. The idea would be that if we got it approved, we would partner with probably a couple of plans and some of their network partners. We would put a design team together that would be plans and providers and peers to design how we want this to work. We would design a pilot. We'd probably pilot it for a couple of years, and when we figure it out, we would then bring it to scale and add it to the overall benefit package of for these HARPs. So you would only be eligible, you'd only be able to access these home and community-based services if you were in the HARP line of business. So somebody would be determined eligible for the HARP, and there would have to be an assessment there after the initial group of people that were enrolled. And then once you're in the HARP, you would be evaluated to determine whether you were eligible for these home and community-based services. And if you were, you'd have to go through a full assessment. A plan of care would be put together, and depending on which of these services, along with the state plan services that you would need to achieve your the goals in your service plan, you would have access to them. We're hoping to get some upfront money through CMS through this mega waiver to start to seed these services. If that happens, we may be able to get some of these off the ground later next year. And then we would grow these services as we're at with the plans, initially with the seed money, and then as we free up dollars from better management of inpatient services and reducing the readmission rate, those freed up dollars that are expended in that very expensive environment, in my mind, if somebody keeps being admitted to the hospital, there's really a problem with the plan of care. Those freed up dollars will go partly to expand treatment, but more so, I think, to grow these home and community-based services. So So again, the plans through the qualification process are going to have to demonstrate that they have the staff and the knowledge to manage these home and community-based services. And the reality is that most of the mainstream plans right now don't have that. They're going to either have to hire in expertise, partner with a specialty behavioral health plan like a Magellan or a Value Options or a Community Care Behavioral Health or a Beacon, or partner with networks. Another model we're looking at is if a plan wanted to do it in-house and they hired in some expertise and they had a governance model with their network partners, where their network partners were at the table to demonstrate that their expertise was at the table for the design of a recovery-oriented system, we would look at that as a possible model to demonstrate that the plan had the knowledge and the capacity to basically help us transform this more medical model, an old community support system, into a true recovery-oriented system. Because ultimately what we want to do here is we want to transform the system of care to do that. Plan qualifications, I'm not going to spend too much time on this, but you'll see this in the RFQ when it comes out. But the point here is that these are things we're going to be looking at: underutilization and overutilization of behavioral health services. The plans are going to have to manage the AOT program. They're going to need your help with that. They don't know what to do with that. Plans don't like court-ordered care because they can't manage it as well, but it's a given. They have to manage it. They're going to need your help there. We're going to be looking at emergency room and crisis service visits, pharmacy utilization. So when you look at this list, or when you look at the RFQ, think about what you could bring to the table to a plan to help them meet these responsibilities as network partners. But I wanted to spend a little time on this. This is what we want to accomplish. Everybody in the HARP will have a care manager, and they'll be getting that care management through a health home, and it'll be an integrated plan of care. We want to reduce unnecessary inpatient and the ER services, again, to free up those money, but more importantly, we don't want people to have a 20% chance of being readmitted to a psych unit when they're discharged from a psych unit. I mean, we all know that that's not therapeutic, it's not clinically good. And those would free up the dollars to help us to transform the system to a recovery-based system. In order to reduce that, we're going to have, I think, better care on inpatient, but we're going to have better discharge planning. And CMS in their health home guidance talks about critical time intervention when somebody's discharged from an inpatient unit. Their services wrapped around that person in an intensive way, especially if they're a person that's readmitted a lot. If there's a person you can't find except when they're in the hospital, and now your information system has told you this person that's real expensive that you can never find when they're discharged is in the inpatient unit, and shouldn't you assign a high-end skilled care manager to engage that person while they're there and work with the person to put a plan in place to redesign their behavior around their own care so that they don't go to the ER when there's a problem, that you connect them with care. And if they're in the psych unit and you have access to their medical record and you find out they also have untreated diabetes and hypertension because 2 weeks ago they were in the hospital because of their blood level, shouldn't you be talking to them about that at the same time? So that's how we're going to get our arms around that. Increase ambulatory engagement. When somebody's discharged from a hospital, we want more accountability on the ambulatory side. If somebody doesn't show up for an appointment, accountability about engagement, either through the care manager or the outpatient provider. And then the inpatient savings will fund these rehab services. But this last point I think is critical. This is really a systems approach to care, and it's a culture of accountability and recovery. So we're not just talking about these siloed changes. We're talking about a system of care that comes together that all has the same values around the individual, with information systems that could inform better approaches. With an overlay of accountability, every network partner is accountable. So of course, if somebody's referred to me from an inpatient psych department and they don't show up for their appointment, of course I'm going to reach out to that person and try to find out where they were. I'm going to call their care manager. It's just a given. And is a recovery overlay. So the goal here isn't to stabilize people's symptoms, keep them out of the hospital, and have them sit in their dark apartment all day. The goal here is to stabilize systems, increase functioning, so that people could more fully participate in life, like with full community inclusion, employment, education, friends. That's where we want to get with this. And if we do it right, I think there's an opportunity over the next multiple years going forward to do it. But the point here is that you as behavioral health providers, I think, are going to be the key to this. And we're going to be working with the plans to create a collaborative partnership arrangement here.
Bob, so I just want to pause for a second. We've got about 7 minutes
And I think
left.
we're really done, Peter. I talked about the rest of this. You know, the last slide was we could talk about FIDAs or not, but why don't we go to questions?
Okay. So before I get started on the questions, just to remind our audience, this is going to be archived. The slides will be available. You can get them both at the McSilver website, and we welcome you to do that. Bob, this has really been phenomenal. It's offered a lot of new information, and I want to thank you once again for your time. So one of our listeners wants to know, what about children? Much of what we've talked about this evening has been focused on adults. Children have very special and unique needs, especially educational needs. And so the question is, what's the planning for children?
Well, as I said in the timeline I gave, the children's behavioral health dollars won't be coming in until 2016. And when we did the Medicaid Redesign work group on bringing behavioral health dollars in, we actually had a subcommittee on children, and the report on our website from that document actually has a section on children. And within the Office of Mental Health, Donna Bradbury, our Associate Commissioner for Children, is the lead on that, and they're working to design the children's component. That committee of stakeholders is still engaged, and they meet periodically to do that design. They're looking at waiver services there too. We have a children's waiver, and we're looking at expanding that. So, just to be assured, there is a very discrete focus on children. We've delayed it a year, partly because you can only do so much at once, and partly because there's even additional complexities with children, with the family and the broader system of care, and that Donna's our lead person for that. She's working with a team of people from the health department and also OASIS, because as we know, especially in adolescence, there's substance use issues with young people too.
So I can also tell you that the Coalition for Voluntary Mental Health Services in the city here is also very focused on children, and if you're a member of the coalition, you should key into their children's subcommittee. The next question, Bob, comes from a residential provider, and they're asking, what about residential case management that's out there now, and whether or not that's going to be folded into HARPS and managed care as this new system unfolds.
Okay, so assuming if you're talking about residential case management, you're probably talking about the service dollars related to supported housing. So that's what I'm going to speak to. As we get these 1959 services with a housing focus, we want to have mobile rehabilitation to support people in housing, whether it's housing that is funded with a mental health subsidy, or whether it's housing that people access themselves, whether they're living with their family, whether they have a Section 8 certificate. So we want mobile housing supports to support people in housing across the board. There's an open question about the service dollars we have in supported housing now. As we get our arms around this, would it make sense to bring Medicaid in that, to leverage Medicaid dollars, and then to have some additional dollars to expand services? That's, we're not sure where we are there. Along with housing, just for some of you might not know, we have a lot of Medicaid money in the rehab option in housing. Now, this isn't the supported housing. This is our licensed community residences, the older group homes, and the licensed apartments. The bringing that money into managed care has a whole other list of complexities, and because of that, we've decided that we're not going to bring the Medicaid rehab option housing dollars in until 2016. We're delaying it a year, and we're starting to work with ACL, the Association of Community Living, to partner with them to talk about the best way to bring those dollars in. So there's the dollars in supported housing that aren't Medicaid and should Medicaid get involved, as opposed to the Medicaid rehab dollars we already have embedded in our treatment apartments. And now that Medicaid money, that rehab money, is not going to come in until 2016.
Okay, I think we have time for one last question. When you talked a little bit about the pharmacy benefit and folding the pharmacy benefit into the HARPs and into the managed care plans, a question came up about whether or not there's going to be any work done on ensuring that the formularies that managed care plans come up with are consistent with the medication patterns of clients they're going to be serving in these HARPs and managed care plans.
Yeah, the pharmacy issue is very, very complex, and we actually have a work group with the health department that includes some behavioral health stakeholders looking at the behavioral health pharmacy, because, as you know, pharmacies moved into managed care. We're having an active engagement on that. In fact, I just got another note today about an upcoming meeting. And managed care plans are part of that work group. So we are looking at the issues and, you know, how much oversight should a plan provide to a psychiatrist versus primary care? I think the concern is there's a lot of behavioral health medications prescribed in primary care that may or may not be appropriate, but is there a differential look between primary care and specialty agencies? So we are going to be working with the plans around pharmacy as we move towards the HARP benefit. And what we don't want to have is that you start with the cheapest medication. You start with the most appropriate medication. On the other hand, if there's a range of options that are before you that could be equally effective, we also want them to take side effects into. Okay, so if they're thinking about somebody that has schizophrenia and they want to try them on a second-generation antipsychotic, and one has less of a metabolic profile than another, and the indication is that either could potentially be equally effective on a trial, shouldn't you go with the one with the lower metabolic effect? We also want to look at drug-drug interactions. We want to look at the adequate dose and duration. So you know, we are aware of the formulary issues on when you move a pharmacy into managed care, and the health departments become aware of that, and we're actively addressing it.
Great. I think we're just about out of time. Once again, I want to thank our audience for being with us tonight, and on their behalf, Bob, I'd like to thank you for your time. This has been really very, very helpful, and perhaps sometime next year as this unrolls, we can have you back.
For sure, and then maybe this is the first time I've done this, and there's a sign in front of me to look at the camera, but every time you talk, I look at the speaker, because that's where your voice is coming from. So probably people are wondering why I'm looking off to the side. So maybe by next year I'll have learned to look at the camera.
Now you know what they go through in TV studios. Thanks again,
yeah.
Bob. And
thank you very much.
You can get all this material on our website. I guess that's it, Greg. You can cut us off.
Thank you.